Hello, everyone. Thanks for joining. So we're continuing on with our tutorials on glaucoma, and today I wanted to focus on closed angle glaucomas. We'll be discussing mainly today sort of primary angle closure. We'll touch on acute angle closure as well and its management, and then also go on to talk about some secondary angle closure syndromes, and what sort of things can lead to a closed angle, and then in effect a high pressure. So primary angle closure, if you sort of think about it as it's angle closure but without glaucoma. So specifically, it's primary angle closure glaucoma, which is then kind of a pathology, whereas your primary angle closure is somebody who is anatomically got a closed angle, or an angle at risk, and there are ways to manage these patients depending on the on how risky the patient is. So really the main things that predispose you to primary angle closure are things like being female, Southeast Asian origin. Those are sort of more your epidemiological risk factors, but there are some anatomical risk factors as well. So you've either got things like pupillary block, so that's usually to do with having a narrow angle, combined with a shallow AC. And then if you have like an older patient with a larger cataract, like a larger lens because of a cataract, one thing can lead to another, and then next thing you know, you've got pupillary block. But then you've also got a plateau iris sort of configuration. So that's where your ciliary body sort of pushes up against the peripheral iris. And then essentially what that causes is either the iris is therefore prone to having pupillary block, or you can actually have direct apposition against the trabecular meshwork by the peripheral iris. So there are some sort of anatomical things in the eye that predispose a patient to having primary angle closure. And when you're thinking of angle closure, there's sort of a spectrum of disease. So you're starting off with narrow angles. You then have something called iridotrabecular contact, where the iris is touching the trabecular meshwork or covering it. You then have primary angle closure. You have a separate sort of acute primary angle closure attack, and we'll talk about that. And then that will progress us to primary angle closure glaucoma, where you then actually have RNFL loss and glaucomatous damage. So primary angle closure, you've got narrow angles, iridotrabecular contact, and then if you've got those two things plus one of the following being high pressure, um, peripheral anterior synechiae, or symptoms where the patient is telling you they've had episodes which sort of suggest they've had previous acute angle attacks. So if they're telling you, I've had episodes where I've had a really intense headache, blurred vision, but it all settled down by itself. Um, these are all things that make you think about, okay, potentially is this a patient who's actually had subclinical episodes of anterior of acute primary angle closure? That all makes you think that this is a patient with primary angle closure, and then you're essentially going to treat them. You're going to think about whether or not they're PACs plus, and I'll talk about that in a moment. These are patients who are essentially going to be treated with a peripheral iridotomy, plus or minus a lens extraction, and if you're going to or if you're revising for your part two exams, then the Eagle study specifically saw that the kind of potential benefit was the same between PI and lens extraction, but actually lens extraction seemed to carry slightly better IOP control and a better quality of life. So, these are patients who definitely should be considered for early clear lens extraction. So the PACS plus criteria, so primary angle closure plus, these are all patients who you might consider doing a PI or a lens extraction, despite no glaucomatous damage. So if you're thinking about a patient who has only one good eye and you're trying to preserve the vision in that eye, are they a vulnerable adult? Is this somebody who's not going to be able to present to healthcare easily? Is this someone who's not going to be able to vocalize their symptoms easily? Is there a family history of glaucoma and acute angle closure? Do they live in a remote location, and would it take them a while to seek medical attention? Do they have diabetes? The reason with the diabetes is that these are patients who are probably going to have frequent dilation, either because of, for example, the screening program, or they're in medical retina clinics. Are they high hyperopics? Are they more at risk of having an angle closure attack? And then are they on any sort of antidepressants with anticholinergic effects, which can actually also predispose them to an angle closure attack? So, if any one of these are met or more, then you're going to consider these patients, despite no evidence of glaucoma or no evidence of previous angle closure attacks, to have a PI or a clear lens extraction, because you're worried about them actually not seeking or not getting the medical attention quickly enough, or they're patients who are more at risk of developing an acute angle closure attack. So then you've got glaucoma. So this is essentially primary angle closure plus glaucomatous damage. And you're going to treat these again the same way. But some of these patients, once they actually develop the glaucoma, even once you've given them a PI or once you've taken the lens out, while in some patients that can be curative in terms of their pressure, some of them actually do need chronic IOP lowering. So these are patients who will chronically have high IOPs, and that might be because of the secondary effects in terms of having peripheral anterior synechiae, a blocked trabecular meshwork. So these are patients who may need chronic IOP control. And just bear in mind that these are patients who are probably a bit hyperopic, and sometimes even just doing the cataract operation itself or any other surgeries can actually cause aqueous misdirection. And in a later sort of session, we'll talk about your sort of iatrogenic glaucomas and things that we can do as ophthalmologists that sometimes cause high pressures. So we'll talk about aqueous misdirection in another session, but just bear in mind patients who are predisposed to primary angle closure, if they're hyperopic, then these are patients who even a cataract operation can cause aqueous misdirection. So acute primary angle closure, these are your patients that are going to come into your eye casualty. It's one of your ocular emergencies, and it's going to be something that's going to get you out of bed overnight. So these are patients who are going to come in with intense pain, redness, halos to their vision, usually due to that corneal edema. Blurred vision again for the same reason. They're going to be vomiting because of that high pressure. They'll be feeling very nauseous. They'll have a very high IOP. So these are patients who are going to see IOPs in like 50 to 80. They'll have corneal edema, that sort of classic fixed dilated pupil. And when you're seeing these patients, do just consider secondary causes. So do they have a very sort of dense, massive lens? What else could be going on that's actually driving the angle closure? But primarily, these are patients who are going to need acute treatment. So immediately, you're going to lower their IOP with drops and IV acetazolamide. And those drops are going to be a mix of things like beta blockers, your sort of sympathomimetics, or something like an aproclonidine, steroids. You're going to consider giving some pilocarpine, especially to the other eye if you're thinking that this patient is going to get PIs. And then you're going to give them IV acetazolamide. So give them the 500 milligram stats, just check that what their renal function is doing. And try to lower that IOP. And essentially, if that doesn't work, then you need to just repeat your IVs and try and bring that pressure down. There are other things that you can consider doing to try and reduce that pressure in the acute setting. So something like a gonio massage. So if you get like a four mirror gonio lens, which sits only on the cornea, so it doesn't have that sort of stilt that sort of sits around the limbus. So you want something that's going to sit purely on the cornea. And if you push in, that sort of apposition can sometimes open your angle. It's a very temporary measure, but it can sort of give relief to the patient, lying them supine, especially if you're considering that there's a sort of lens component to it. And it just allows the lens to sort of fall back away from the pupil to try to relieve that pupillary block. And then also, if you're in a medical if you're in a hospital that has sort of your medical colleagues helping you, then IV mannitol can work really, really well to bring that down. That should say 1 to 1.5 grams per kilogram, not 1 to 15 grams. That would kill the patient. So 1 to 1.5 grams per kilogram in terms of how much you're going to give of that 20% solution. These are patients who you're going to want to give a PI to as soon as possible. And then, if things still don't work and the IOP is still not coming down, you can consider things like cyclodiode, potentially even early surgery in these patients, despite them having a hot eye. And there are situations where patients have had an AC paracentesis. The thing that you need to worry about with an AC paracentesis is if their pressure is, 50 to 60 and you're trying to put a needle in the front of the eye, you can end up with an expulsive episode. So if the pressures are sort of hovering in the high 30s to low 40s, you can potentially a bit more safely do an AC paracentesis. And the way I've seen that done really well, and the way I've done it myself really well, is if you just get an insulin syringe and you remove the bung and you simply insert that needle inferiorly, sort of kind of parallel to your iris, and then just leave it there. Your aqueous will slowly leave through the needle into the barrel of the syringe, and just by letting it do that, just with hydrostatic pressure, then you can have the pressure in the eye normalized down to your sort of high teens. So you don't need to actually take anything out. You can just simply remove the bung of the syringe. But bear in mind that you should be doing that with some sort of senior support, and definitely you're not doing that at very high pressures. Just as a warning to do with the an AC paracentesis. So we'll talk a bit about your sort of secondary closed angles. So there are four main sort of syndromes that I think are worth knowing about that can cause a secondary closed angle. So iridoschisis, which is quite rare, ICE syndrome, posterior polymorphous dystrophy, which is very similar to ICE syndrome, and then sort of something again quite rare, epithelial downgrowth. So starting off with iridoschisis, this is essentially, what it says. So it's a separation of the layers of your iris. And what can happen with the anterior leaf is it can either sort of actually cause direct apposition of your trabecular meshwork, but then also that posterior leaf can also cause pupillary block. So both sort of leaves can be problematic in the situation of iridoschisis, and it's usually associated with non-ophthalmos. A PI can help to essentially create another passageway for the aqueous humor to go through, and then these are patients who are going to get usual glaucomatous management. There's not a lot that you can do surgically to help repair this, but essentially these are patients who are going to need the chronic management of their glaucoma. Eye syndrome, well, we might touch on this when we're talking about corneal pathologies as well, but essentially you've got these sort of three main subtypes to eye syndrome, and it depends really on what sort of tissue is most involved. So Chandler syndrome, you may have heard about. This is kind of predominantly corneal findings, and then you've got essential iris atrophy, which is predominantly iris findings, and then you've got Cogan-Reese, where you have an iris nevus. Now, eye syndrome is typically in your sort of younger female, so 20 to 40 years old, coming in, it's unilateral, and there's a 50% risk of glaucoma. There is a sort of underlying predisposition, sorry, underlying risk factor. There's an association potentially with herpes simplex in terms of the development of eye syndrome. And these are patients who are going to come in either presenting with sort of symptoms of their corneal problems or symptoms of the pressure. So with the corneal issues, these are patients who are going to have an endothelial dystrophy. They'll have guttata, they may have corneal edema, blurred vision. And then if they do then develop high pressures because of what's going on at the angle, then again, pain, they can have high pressures and they will need both the glaucoma and corneal elements of their disease managed. So this is a patient here that you can see on the in the picture on the right hand side. What you can see there is this is a patient who's had a previous graft, probably again secondary to that endothelial dystrophy with ice, and they've got correctopia as well because of that iris atrophy. So they have a mixed picture in terms of what their iridocorneal endothelial syndrome is in this specific patient. And what you'll find specifically is that the other eye will be normal. The sort of main difference between ICE and PPMD, because they can be quite difficult to distinguish clinically, is that PPMD is bilateral and it tends to present in younger patients. Younger than Eye syndrome, and it's usually autosomally dominant, inherited. So these are patients who are going to have a family history. PPMD is less likely to progress into glaucoma. So you're looking at more kind of 10 to 20% of patients with PPMD will progress to glaucoma. They typically have more corneal issues, but Eye syndrome definitely carries a very high risk of progressing to glaucoma. So that pressure really does need to be managed. Finally, with epithelial downgrowth, so this is usually a kind of disordered response to either trauma or surgery. So this is a patient who's either had a penetrating trauma to the eye or they've had a previous kind of otherwise routine cataract operation. And then that epithelium will grow through the wound in down and then start to grow across the endothelium of the cornea. And then what happens is that it can proliferate in the AC. So it can then start to grow all over the place, touching down into your iris, covering your trabecular meshwork. And it unfortunately carries a usually quite a poor prognosis because it's very, very difficult to manage. The IOP can be very high, and these are patients that don't necessarily respond very well to surgery. Things have been tried, things like, injections of antimetabolites into the AC, direct surgical excision, but really it can be very, very difficult to manage, and the prognosis does unfortunately tend to be quite poor. So that brings us to the end of talking about angle closure. Really, the sort of main bulk of angle closure is that you're looking at primary angle closure patients. We discussed the sort of the main things to consider, such as do they have PACS plus criteria? Are these patients who are actually glaucomatous? And then how to manage an acute angle closure. And then we also touched on just some syndromes that can cause a secondary angle closure. The way to think about this, and as I've said before in the kind of introductory session to glaucoma, Glaucoma is sort of, it's really useful to know what the underlying mechanism is driving that increase in pressure, because if you're not treating the underlying mechanism, or if you don't know what the underlying mechanism is, you can't in good faith kind of understand what the prognosis of that patient is and whether or not your treatment is going to have any effect. So, distinguishing between an open and a closed angle is really important in understanding what could be going on in the eye. So that brings us to the end. Thank you very much for listening. Again, please do fill out that feedback. There's a link in the description if you're watching this online. Thank you very much for joining, and we'll see you at the next one.